today. Yeah, this topic's huge. Oh, I'll mention FGM at the end. Remind me, because that does come up, and I was gonna make an SBA on it, and I've completely forgotten. I've just remembered, but I'll tell you the answer basically at the end. Remind me to do that. But we'll go through miscarriage, ectopic pregnancy very briefly, dysmenorrhea, and these topics that I've picked are probably the ones that come up the most in the exams. And also I've thrown in some potential OSCE stations that may or may not come up. I don't know, but I think they may have come up in the past, or they're easily things that can be discussed with a patient. So we'll go through those as well. Cool. Right. So we'll crack on. We've done this to death. So basically, for this gynae lecture, because I know gynae is a massive topic, I'm basically going to go through some targeted SBAs which seem to ring a bell from the exam. And I'm not going to sort of go through presentations, because I think that's the easy sort of part of medicine. I think, and especially in 5th year, they want more management. So we'll be going through management more than presentations. I'm sure you guys can, you know how like fibroids present, for example, like if it's menorrhagia. But we'll crack on with miscarriage. So we've got a first SBA. Yeah, we're going quick. We'll rapid fire this year, don't worry. Where's the SBA gone? Can I see it? Oh, sorry, ignore me. Okay, cool. So yeah, C. So I said I wasn't going to talk about presentation much, but I do think this came up. I remember them sort of asking what type of miscarriage it was. I wouldn't worry about too much more. I've summarized them there for you, like the bit of the buzzwords and things you might expect to see in a STEM. But basically, if the cervical os is open, it's always going to be inevitable. More often than not, it's usually closed. Yeah, you can go through this in your own time. Next question. Just make sure you learn the presentations of each one. Okay, nice. Yeah, so you guys, vast majority of you getting this right, and this also can be a bit confusing. So the answer to this is vaginal misoprostol. Basically, this is the sort of medical management when you're suspecting a miscarriage. The other ones, I wouldn't worry about too much. Just remember this fact. It's one of those that realistically, I don't think you'd be making this decision, but they could put it in an SBA. I think I talk about this a bit later on. So oral mifepristone as well can sort of confuse people because they sometimes can add them together. But NICE actually don't recommend this for the UK. It's more like in the US where they do that. Basically, the vaginal misoprostol just sort of helps the uterus contract and expel the tissue. So just a little fact you need to sort of know. All right, next. Yeah, nice. So vast majority of you getting this right. So this is important, because that being said, you wouldn't necessarily be in charge of, deciding who gets what, but it's important to know when someone is like severely unwell or it's life threatening, basically. So this sort of stuff, I think you do need to know. So basically, this patient sort of has an evidence of a infection. Basically, they're pyrexic, and they've got offensive smelling discharge, and they've got some abdominal tenderness. So basically, there's a few criteria that you sort of need to know when you should just do surgical management and you can't do medical. So basically, if there's an increased risk of hemorrhage, if they've got an increased risk of hemorrhage, they've got evidence of infection, then you're sort of tending to want to move towards the medical management. Yeah, that sort. I think I've got it summarized somewhere. Okay, no. But yeah, basically, someone severely unwell, you can't manage them medically. You need to manage them surgically, and you guys spotted that, so perfect. All right, so we'll move on to recurrent miscarriage. So does anyone know the definition of this? Oh wait, I can't see the chat. Yeah, greater than 3, basically. So 3 or more consecutive spontaneous abortions. Do you know any causes of this? Yeah, antiphospholipid syndrome. Okay, nice. Hypothyroid. Yeah, APS is the main one. So antiphospholipid syndrome, polycystic ovarian syndrome, uterine abnormalities as well, some genetic disorders, and then thrombophilias. So what sort of management would these patients need? Refer, yeah. Look for underlying cause and refer to specialists. You guys wouldn't need to know any more than that. That's sort of your remit, basically. Just sort of something to be aware of. Yeah, like I said, it's very specialist. Okay, miscarriage summary. Nice. So make sure you know the types. So we've got threatened, missed, inevitable, and complete. Know how they present, because you may or may not get asked about that. And then management, less so as important, but just remember that surgical sometimes is indicated by certain things, and I've summarized it there for you, basically. And I think I saw in the chat like people asking about doses and stuff. I wouldn't worry about that too much. Just know the drug, basically. Okay, cool. So that's miscarriage in a nutshell. We'll move on to ectopic pregnancy. So a 23-year-old lady presents to the emergency department with severe abdominal pain. So this is still an acute abdomen. Just thinking about like an ABCDE situation. What other differentials are you thinking about? Appendicitis, yeah, nice. Ovarian cyst rupture. Yeah, pancreatitis as well. Ovarian torsion, that's an important one, especially in gynae. I've not gone over it too much today. AAA, yeah, nice. Okay. So, yeah, ectopic pregnancy would be top of your list. The ovarian torsion, appendicitis, pelvic inflammatory disease, renal colic, pyelonephritis. So these are all things that you want to be keeping in your mind as well, especially if it's an ABCDE. Okay, so just a bit of like focus history, like targeted questions. What risk factors might you want to ask about when taking a history for ectopic pregnancies? Yeah, previous pelvic inflammatory disease, endometriosis, IVF, coil, yeah, good. Tubal surgery, nice. Well in, guys. So they're basically what I thought of as well. Nice. The other thing as well to sort of think about, we just talked about, is miscarriage. So this could also present quite similarly. So both can present with pain and vaginal bleeding. But one thing to remember is that pain in an ectopic is often the first and dominant symptom. And if vaginal bleeding does occur, it's much more minor in comparison to a miscarriage. So just something to think about there. Okay, so what are the typical things you'd find in the history? Like what things might they say if you're taking a history from them? So shoulder tip pain, yeah, nice. Missed period, yeah, good. Amenorrhea, yeah, nice. Sudden onset, yeah, good. Syncope, nice. Yeah, shock, important. So yeah, recent or missed period. So 6 to 8 weeks is sort of the classic time for presentation. If it's coming a bit later than that, because obviously the fetus is growing quite large, it may suggest miscarriage if it's past 10 weeks or so. They might have vaginal bleeding, like lower abdominal pain, shoulder tip pain, and shock. So as you mentioned, syncope. Cool. All right. So what clinical features, so when you're examining them, might you find? Quite similar question, to be honest. Cervical excitation, external tenderness. Yeah, good stuff. First one's for you. Jeez. Cool. So yeah, abdominal tenderness, left or right iliac fossa. They might have pelvic pain, cervical excitation. I believe that was called the chandelier sign. It's apparently like when you're examining, the patient sort of like jumps up and throws their arms up in the air. I don't know why it's called chandelier sign, but whatever. PV bleeding, they might be hemodynamically unstable, they might have low blood pressure, high heart rate, and there may be a palpable mass. Cool. So what are the next best investigations for this patient? Yeah, pregnancy test, transvaginal ultrasound. They're the main two. They're the things that you want to be doing. So yeah, any woman of childbearing age with an acute abdomen, I think even any woman of childbearing age should be given a pregnancy test at the door. So yeah, pregnancy test and then transvaginal ultrasound, and then your basic observations as well. So move on to the next SBA. Yeah, get help as well. Nice. Yeah, excellent stuff. So as I mentioned before, similar to like miscarriage, but this is a bit more pertinent. So you could potentially sort of see this in an A&E setting, and you would sort of be expected to kind of know that this patient was unwell and they may need to be referred to surgeons, basically. Yeah, surgical management is something that you need to spot. So if there's a fetal heartbeat present, then surgical management is the only option. And the other criteria I've added there for completeness. So significant pain, it's obviously quite subjective. I don't think they'd put that in an SBA. If there's a large, basically the ectopic pregnancy is quite large, and the beta HCG is over 5,000. I feel like they wouldn't sort of throw in these rogue numbers if they gave this to you as a question. I think they'd identify that as a fetal heartbeat present potentially. So just something to be aware about. You need to sort of know that. And then I've mentioned here that methotrexate is used in the medical management. Repeat beta HCG levels. So that's when you're done in expectant management. Potentially might be worthwhile going over those. Expectant management, I feel it's probably rarely done because they're quite concerned. You can be quite concerned about these patients. But yeah, just remember that the drug used if they would want medical management or they're fit for it is methotrexate, and they need to be followed up if they're having medical management to check whether the beta HCG levels are falling. But I wouldn't worry about it any more than that. I think recognizing when you need surgical management is the most important, and I certainly didn't learn any more in-depth details than that. So we'll move on to dysmenorrhea. So this is quite a common complaint. Also, it's worthwhile remembering that these presentations can crop up in GP as well quite a lot. So they may be mentioned or overrepresented in the exams. But anyway, dysmenorrhea is pain occurring with menstruation. Most women do experience some pain, but basically dysmenorrhea is when it becomes quite debilitating. With regards to dysmenorrhea, you sort of want to rule out any sexually transmitted infections that may be causing it. You want to do examination for abdominal tenderness, any mass, bimanual examination, assessing the cervix as well, and then maybe a pelvic ultrasound to look for any underlying pathology, maybe like fibroids or endometriosis. Cool. Oh, and also just to mention primary versus secondary. So basically primary is sort of when it's always been present, and then secondary where if it develops later on. And any patient that develops secondary dysmenorrhea needs to be reviewed by gynecology, basically. But anyway, we'll move on to the management of it. I'm sure you can realize from a stem or a history that this patient has dysmenorrhea. Yeah, nice. So the vast majority of you going for the right answer. So these questions can be confusing with, dysmenorrhea, menorrhagia, and, all the drugs sound quite similar. So basically, first line for primary dysmenorrhea, so painful periods, would be methylminic acid or ibuprofen. They're sort of the anti-inflammatories that you'd use. Oral paracetamol the modality of pain that it's targeting isn't correct, so it's not first line. More than likely they probably use it as an adjunct, but NICE recommend either methylminic acid or ibuprofen as first line. Tranexamic acid is used for menorrhagia, so heavy periods, and then the pill is used second line. So I see why some people put it, and then intrauterine systems more used in menorrhagia. Okay, so we'll move on to the next question. Yeah, good stuff. So what I was getting at here was endometriosis. So quite a common cause. Well, I don't know how particularly common it is, but they do like to ask about it, and it gets mentioned quite a lot. And basically, I think this is one of those facts that realistically you're never going to sort of be ordering a laparoscopy for a patient with endometriosis. But you sort of need to know that it's the gold standard investigation and management. So yeah, just something to keep in mind and just know. But you guys seem to know that, so good stuff. Okay, so move on to menorrhagia. So what I'm going to do here is make this into a bit of an OSCE case. You may get asked to do a sort of gynae history, which is slightly different from your normal sort of history taking. There are a few specific things you need to ask. But anyway, how do we define heavy menstrual bleeding? Yeah, affects the woman. So basically what the woman says is heavy for her. So previously it was quantified, but now it's just whatever the patient considers excessive. Okay, so we'll go through the sort of obs and gynae history taking format. So the things you want to ask about are like the menstrual cycle, any obstetric procedures or children that they've had before, sexual history, any contraceptive history, their smears, and then any urinary or bowel changes for things like prolapse. So this is the sort of structure and things that you want to cover when you're taking a ONG history, and we'll go through them individually now. So what sort of things are you going to ask about in the menstrual history side of it? Last menstrual period. Yeah, good. Menarche, yeah, nice. Age, yeah, good. Cycle length, menopause. Regular, irregular, yeah, good stuff. So when was your last menstrual period? Ask about menarche, regular cycle, how long is it? Is it heavy? Is it painful? Does this affect your life? It's good to ask those questions early on. Has it changed recently? Have you experienced any intermenstrual bleeding or postcoital bleeding, pain on sex, and any discharge? So these are sort of things that you want to be covering in this section. So moving on to like an obstetric history side of it, what sort of things would you want to be asking there? Previous pregnancies, yeah, good. Any miscarriages, yeah, nice. Top. So yeah, termination of pregnancy, good. Ectopics, delivery type, complications, yeah, any problems in previous pregnancies? Yeah, these are all good questions. So how many children, how were the deliveries, any problems pre or post labor, any other surgeries? Good stuff asking about termination of pregnancies and ectopics and miscarriages and stuff. And then family planning, so any future children that you might that they might want, because this can affect the management. But yeah, nice, good stuff. Good thoughts you guys had there. So that's sort of the obstetric side of it. And then moving on to sexual history. So we kind of went through this on Friday with HIV. But any other ones you want to? So what would you be asking? Yeah, regular partner, good. STIs, yeah. How many partners in the last 3 months? Yeah, good stuff. Sexually active, yeah. First of all, yeah. Type of sex, yeah, good stuff. Basically similar to what you guys said. You sexually active, partners in the last 3 months, STI screening symptoms, and asking about the relationship is also extremely important, because I remember in the GP days that we did with obs and gynae, there was a station, and I basically was taking a history similar to this, and then I got onto social history and asked about how things were at home, and how was her partner helping her with during the pregnancy. And then she went on about how she was getting abused and he was attacking her and not feeling safe at home. So it is an important question to ask for sure, whether or not they may or may not give that sort of thing to you in an OSCE station. I can't say because it's quite difficult, and it's something that could take quite a long time in real life, and obviously you want to sort of make sure the patient's safe and ask as many questions as possible, but it's just something to bear in mind. So please do ask about relationships, and you can ask things like, do you feel safe at home? Is your partner supportive? Ask about other kids at home, do they feel safe, etc. So it's good to throw those questions in there for sure. So contraception history. So what sort of things might you want to ask there? Yeah, definitely ask a brief sexual history in the gynae side of it. I should have elaborated that a bit more on the sexual side. Yeah, what current and previous types are you on? Compliance, any side effects, plans for children? Oop, I've lost the chat. Yeah, good stuff. So are you using any? What types? How long for? Any changes? Any problems, etc. What has worked in the past? Yeah, nice. So you guys are thinking of stuff that I've not even got on here. So it's all good, relevant stuff. And then cervical smears, we'll not label this one. So when was your last one? Basically, are you up to date with your smears? What were the results? Have you had the HPV vaccine, etc.? So just something to add on at the end. There'll definitely be a mark for it. And then prolapse symptoms, so any sort of urinary frequency, any difficulty urinating, bowel changes like a dragging sensation, etc. So that's sort of basically the crux of like your gynae history. But we'll move on. So just something to keep in mind. So what top differentials for this lady that we've got here for heavy menstrual bleeding? Yeah, fibroids, nice. Given her sort of ethnic origin and presentation of heavy menstrual bleeding, you'd be thinking thyroids. Also, yeah, guys, we're saying polyps, nice. IUD, hyperthyroidism as well, yeah, nice. But these are sort of your top ones, especially fibroids, basically. Cancer as well. Okay, so we'll move on to the next question. Yeah, okay, you guys recognize what this was. Once again, I don't know sort of how common this is and whether or not how clinically relevant it is, but may or may not get asked in your exams. It's important to sort of realize when something's benign and when something's more serious. But given the history, the uterus is large for dates, so that suggests that potentially there may be some fibroids in there. But this is red/fibroid degeneration, and it's managed conservatively. Basically, the blood supply to the thyroid isn't enough to supply it, and it sort of just starts to degenerate, basically. Just sort of be aware of how that might present, and they'd sort of make it obvious like this if it were to be the case. Just something to be aware of, and then I've explained why the other ones are wrong. I wouldn't get too bogged down in the management of fibroids. Once again, it's something that you wouldn't necessarily have to you wouldn't be dealing with, even if you're a sort of obs and gynae F1. It's more specialized. Just be aware of how fibroids present and this red degeneration. But myomectomy is management for large fibroids that are causing fertility problems. Okay, so what investigations will we need to do for our patient? Transvaginal ultrasound, yeah, nice. Basically, that's what you want to be doing. FBC check for anemia, yeah, good. Thyroid test as well, nice. So FBC check for any anemia, clotting disorders, potentially may have a bleeding disorder or a liver problem that's messing up the clotting factors. And yeah, thyroid function test I should have included in there, so that's good. And then transvaginal ultrasound. If it's sort of clinically indicated, given a history and stuff, you want to be doing that to rule out fibroids or potentially something else more sinister. Nice. Okay, so Oh yeah, I did include tests for endocrine diseases. Okay, fine. But yeah, so basically the sort of symptoms that would indicate a transvaginal ultrasound. Um, intermenstrual bleeding, postcoital bleeding, pressure symptoms as well from the fibroids if they're large enough, and also if you can feel one on examination, you can feel them as well. In clinic, I remember in fifth year, a lady had a large fibroid, and you could definitely feel it when you're doing an abdominal examination. So just things to think about there. Okay, nice. So move on to the next SBA. Yeah, good. You guys have smashed that one there. Yeah, so basically this patient has menorrhagia. Um, as there's heavy blood loss and it's affecting her quality of life. And given that it's been like that for as long as she remembers, it's probably not due to any sort of underlying pathology. The most important thing about the management here is whether or not they're trying to conceive. So, given that this patient has said she's got no plans for children in the future, the IUS is the sort of first line management. It reduces the blood flow and it causes thinning of the endometrial lining. And it also helps as a effective contraception. If they don't require contraception, then you can give tranexamic acid. So this is the anti-fibrin, something like that, fibrinolytic. Can't remember off the top of my head, but basically it helps with bleeding. You can give methylmenic acid alongside that if they are in pain as well. But basically that's it. I'm sort of summarizing that there. Yeah, so tranexamic acid first line if the patient does not want contraception and no associated pain. You can give the pill second line after the IUS. Nice. And then refer to gynecology. So reasons for referral would be sort of menorrhagia that's not responsive to any treatment. If they've got compressive symptoms, so suggestive of fibroids, iron deficiency anemia that's not responsive to any treatment, and then if you're potentially worried about a malignancy. Okay, so polycystic ovarian syndrome. I'm not going to go into too much detail about this. Just going to give you a few SBAs for it. It's one of those like quite complex topics and quite specialized. Can be managed sort of. We'll go through it basically. Which of the following are the three? Oh, you guys can read. Yeah, well done. You guys basically know how it presents. So this is the Rotterdam diagnostic criteria. This is a bit sort of a vague adaptation of it. So you can also have not just clinical evidence of hyperandrogenism, but what's the word for it? Like on blood tests, basically. I don't know how you say that. And polycystic ovaries on imaging, I think it's like more than 11 or something. Or that if the ovaries are quite large but nuanced, I wouldn't worry about that too much. Yeah, good. Vast majority of you that getting right. So these are some, I've given you basically some risk factors and causes of these different types. You can go through them in your own time. I can't remember if they sort of ask questions like this now. But that being said, if this came up in a history, or if you're talking about other things in a gynae history, it's always important to have some sort of ideas in the back of your mind what things can cause or increase your risk of certain cancers. Yeah, good. Vast majority of you once again getting this right. I wouldn't worry about this too much. It's sort of specialized again, but I just seem to remember this being quite familiar in my SBA. And the answer that is most suggestive is increased LH-FSH ratio. Don't ask me why. I don't know the physiology of this. I don't think they fully understand sort of how it and why it happens. But yeah, and normal testosterone. So it can be normal, but it also can be raised. So that's why I kind of like left it. That's why I didn't put that as a single best answer. Okay, so management for this now. Yeah, good. Excellent. You guys getting that right. I've just seen on the chat why endometrial cancer more for polycystic ovarian syndrome. It's because if you're oligomenorrheic, you're not shedding your uterine lining as often, and you can get endometrial hyperplasia, and it sort of builds up. It's just not healthy for it to be there, and I think that's why it sort of increases the risk of endometrial cancer. But going back to this, so basically, so if they want to conceive and they find it difficult to conceive, then you give clomiphene. That just sort of helps. Metformin second line, better in patients who are overweight. Sometimes they use it alongside. I've sort of explained like why each one and where it is used. I think if they weren't wanting to get pregnant, then you just give the normal combined oral contraceptive pill to sort of help regulate the cycles. But that's basically all I would sort of know for this condition. It could well come up in a history, so it's quite important to know how it presents and some basic management given what the patient might want. Cool. Right, we'll move on to cervical cancer, and we'll do it as a type of OSCE case. So I understand that this changed not too long ago, maybe a year or two ago. So if I've made any mistakes, I'm sorry, because I remember it being different to this. So we'll go through it. If I've done anything wrong, please let me know. But basically, this is sort of like a structure for the OSCE station that they may ask about. Okay, so we've got a 25-year-old lady. She's been invited for her first cervical cancer screening. She underwent the procedure and is here today to discuss her results. So just a bit of background knowledge. So who is the smear offered to? 25 to 64. Yeah, good. So 25 to 64. One important little thing to remember as well is the difference. You get 3 yearly screening as opposed to 5 yearly screening during those different age brackets. And also, they don't offer it to women over 64. You can't request a cervical cancer screen, but whereas with breast cancer, you can. I guess because by that point, the risk is probably so low, it's just not worth doing. But anyway, we'll move on. So with regards to sort of any OSCE station where you're, discussing results with a patient, or you're explaining something about like a procedure, these are just sort of like a bit of basic tips you guys can use. So check understanding at the start. So ask things like, what do you already know about the cervical cancer screening? Do you know who's had one before? Do you know anything about why we do it? Just so those sort of like open-ended questions. Make sure you explain any technical terms. So I'm a bit of a guilty for this. I sort of use jargon quite a lot and then find myself explaining what it means. And I've been asked as well in a history or a station, they were like, oh, what does this mean? So it's just important to remember that, not everyone sort of knows what these terms are. And then sort of chunk and check as well as you go. So, explain something and be like, oh, do you understand this? Is it okay if we move on? Get patients involved as much as possible. You don't want it to be like what I'm doing now and just continuously talking and, verbal diarrhea almost, can't get a word in edgeways. You want to get them involved and, make sure that they're understanding as you go. And then, of course, like normalize everything. So, I make them feel, better about the fact that they might not know what a term means. I appreciate that, not everyone knows about this. You've come to the right place. Like, we're here to help you. Those sort of phrases and stuff, just as you're going along. And it also is quite a sensitive topic as well, and it can be quite worrying for patients. So as far as I'm aware, the NHS has moved to this HPV first system. So this is something that you could potentially explain to a patient. Basically, the sample's tested for the HPV virus first, and then the cytological examination as well. Patients might not know what that means. Explain, we look at the cells under a microscope. HPV is a common virus that most people get infected with. We vaccinate against it. You guys probably know more than I do. But sort of, these are the things that you might want to talk about, or these are the questions that you might get asked about by a patient. Just sort of things to be aware of. I don't want to like give you a script to learn. I want you to just sort of think about what you might say. Cool. So she's come in and you're discussing the results, and on the OSCE brief it says that her results have come back positive, and so she's positive for HPV, and they've had a look at her cells and they're showing mild dyskaryosis. So what sort of things would you ask about, or would you want to tell her in this situation? Yeah, we didn't have an OSCE. Yeah, good. That's important. Like, remind them that it's not cancer. Yeah, good. Yeah. Lots of people get this. Yeah, excellent stuff. Oh, what does this mean? So the patient might ask, oh, what does mild dyskaryosis mean? Like, what is that? Yeah, the cells go back to normal. Most women clear it. The cells are a bit janky. I don't think you do too well in your OSCE if you're saying stuff like that. Yeah, explain what the procedure does, small changes in the cells. Yeah, this is all brilliant stuff. So this is like how I was thinking I might phrase it. So you've tested positive for this virus. This means you've caught it and you've not managed to fully clear it. So we looked at your samples under a microscope and we looked at the cells, and some of your cells are looking a bit abnormal. What are you looking at in the cells? So we look at changes in them. This is called dyskaryosis or abnormal cells. This does not mean you have cancer. Abnormal results are quite common. We're just checking the health of your cervix, which is the neck of the womb. And your results have showed some mild changes. Someone's like gone on. Someone's like typing away. Okay, fine. Cool. Yeah, so your results showed some mild changes. It's important that we pick this up early. We can ensure that this doesn't go any further. So what happens next? So yeah, you guys rightly said she's referred for colposcopy. So your stations are 5 minutes. So I don't know like how much you need to go in about explaining the examination. Like one thing I will sort of go through briefly now is that if you're doing a like explaining a procedure station, you know, you normally do like what happens before, what happens during it, and what happens after. I don't know if you'd be expected to get through all that in that amount of time. But anyway, so what happens next? You referred for colposcopy. Basically, you have it in a more detailed examination by a specialist, tiny camera inserted into the vagina, and it just allows us to directly visualize any changes, and we can use some dyes to help us see. And also they can treat and remove any abnormal looking areas. Yeah, I've literally just explained that. Maybe if it's a 10-minute station, you might get asked to explain a bit more. Cool. Okay, so important that you sort of ice patients and, you know, keep them involved and ask about what's worrying them. Chunk and check-in is so key. You know, it might even be worthwhile icing the patient at the start. Like, she might tell you that, oh, my mother or grandmother died of this, died of cancer. I'm really worried about it. Also, very importantly, it sort of directs like where you're going to go. If the patient tells you, you know, I'm worried about this aspect, you can sort of explain that a bit more, and you get more marks, you know, showing empathy about that and the fact that you've explored the patient's ideas. Also, another like tip, instead of saying that like I understand, I think it's better to say that I appreciate. So I tend to say that because obviously like someone might turn around and say, oh, you don't understand, you don't know what it's like, you're not in my position, da da da. So it's a safer bet to say, you know, I appreciate that this has been a lot of information for you. Is there anything else you're particularly worried or concerned about that you'd like to discuss further? It's sort of, you're icing the patient there. You're confirming that it's been a difficult consultation, and you know you've told them quite a lot, and it just opens it up for them to sort of explore what might be, you know, upsetting them. And then, you know, they might say, oh, I'm worried about cancer. Then you say, I appreciate your concerns, and then you can go and say, this doesn't necessarily mean you've got cancer. We found it early, etc., etc. This isn't just specific for cervical cancer screening. Like this can be applied to all sort of OSCE history taking and explaining stations, etc. Cool. So what if the results were normal? If the results, oh, so she's HPV positive, but there's normal cytology. What happens then? Yeah, repeat in 12 months. It gets so confusing, this thing. So repeat HPV test in 12 months. If this is negative, so she's negative for HPV, then send to normal recall. If she's still positive and cytology is still normal, then repeat again in 12 months. If at 12 months you're still positive for HPV, refer to colposcopy, basically. And then if they've got inadequate smears, repeat in 3 months. Nice. So if there's anything wrong with that, please let me know. I did kind of just, I vaguely learned it again for my exams, but I know it changed. Okay, so we'll move on to endometrial cancer. I think we've been going on for just under an hour. Do you want to crack on? Or do you want a break? There's not a ridiculous amount left, I think. Crack on. Yeah, we want to get to the England game. Although they're already qualified, so what's the point? Classic England, just like getting through. Right, so move on to endometrial cancer. Okay, so I am not going to focus too much on these. I think just knowing the management is the key thing. You guys are probably aware of how they present and stuff. So 64% of her GP complain of bleeding from her vagina despite going through the menopause over 10 years ago. So what's the definition of postmenopausal bleeding? What's med supplement? Cool. There's a lecture at 6:30, so crack on. All right, cool. All right, crack on. So postmenopausal bleeding is defined as a vaginal bleeding occurring after 12 months of amenorrhea in women at the age where the menopause sort of can be expected. So basically anyone who's gone through the menopause and they've got vaginal bleeding. So what other causes of postmenopausal bleeding can you think of? Polyps, yeah, good. Endometrial hyperplasia, atrophic vaginitis, yeah, good. So they're sort of main ones. HRT as well, don't forget. So if they've recently started HRT, within the first few months, they can sort of get light vaginal bleeding as well. Just something to be aware of. So, thorough history, what key things are you going to ask about? To be fair, I can rattle through this if you want instead, if you're anxious. Volume, systemic symptoms, nice. So, timing. So, how long has it been going on for? When did it start? Consistency and quantity of bleeding. You want to do a full gynae and obstetric history, which we've spoken about before, and also ask about specific risk factors. So, have you had any children? When was your menarche? When was your menopause? Etc. etc. So, on examination, what might you be looking for? So, vaginal, you want to do a vaginal and full abdominal examination, look for any obvious masses or abnormalities, any atrophy, do a speculum, look for any bleeding, visualize the walls of the vagina and cervix. It could be a cervical cancer, it could be some vaginal growth or something like that. So immediate testing, this is the most important bit basically. So what sort of things do you want to do? Yeah, transvaginal ultrasound, good. Yeah, hysteroscopy as well. Yeah, nice. Swab for STIs, good. Good. Actually, okay, maybe. Okay. So in the immediate setting, in the GP, urine dip, look for any infection, look for any hematuria on there, protein in the urine, FBC, the anemic, CA125 as well, always important in these gynae cancers. More so for ovarian, but we'll get onto that later. But anyway, but you're quite right. So transvaginal ultrasound, yeah. As I said, CA125 more so for ovarian, but you might be suspecting ovarian. Ovarian cancer can present with a PV bleed as well. It's something you'd want to do. But as you rightly said, transvaginal ultrasound and hysteroscopy. Anyway, next SBA. Yeah, good. You guys need to recognize this. This comes up basically. Okay, so I can see why people put C, but basically the lady presents with postmenopausal bleeding, and yeah, the most likely diagnosis is atrophic vaginitis, and you know the vaginal lining sort of thins due to low estrogen, and it just basically predisposes to bleeding. However, endometrial cancer is far more serious, and it must be ruled out. So, atrophic vaginitis is a diagnosis of exclusion, basically. Nice guidance, say anyone over 55, recommend urgent referral. Over 55 present with postmenopausal bleeding, basically. So you definitely need to know that. So we've spoken about this already. Transvaginal ultrasound, you want to see a normal endometrial thickness, so less than 4 millimeters, and you can do a hysteroscopy with endometrial biopsy. Management, so it's usually good if detected early. They just remove, they do a full hysterectomy and they can remove the ovaries as well. So ovarian cancer, we'll move on to. Right, I think I just do this with SBAs, so it shouldn't take too long, and you're getting the practice there. If she was 54, what would we do? In the SBA, they wouldn't do it because it would just be shit. However, I feel like in real life, it's their guidance, basically. They're not strict things what you must do. If someone's 54, they went through their menopause a long time ago, and they've got a PV bleed, and you do probably refer them. Simple as. Better safe than sorry. Yeah, good. So I actually hated the management of this, and I found it very confusing. But basically, IBS is a diagnosis of exclusion as well. It's unusual to present in older patients, so that's why A is wrong. Arrange an urgent pelvic ultrasound. So there's sort of like a bit of a flow. It's a very ambiguous sort of guidance and flow chart, but I think I've kind of summarized it as best of my ability here. So you do an urgent pelvic ultrasound if you do the CA125 and it's raised. Arrange urgent referral only if they are presenting with ascites and you can feel a mass on examination. Prescribe methods or whatever, a load of rubbish. Yeah, I find this really stupid because I don't understand why you go through all this first and just not do an urgent referral. Like if you're worried about cancer and you know how sinister ovarian cancer can present, I don't know why you faff around waiting and doing CA125 then ultrasound. It just seems a bit just long, and you're delaying the diagnosis basically, but whatever. Cool. Next question. Yeah, perfect. So basically, any suspicion of ovarian cancer, and you found an abdominal mass or a pelvic mass, CA125 and ultrasound test can be bypassed, and you're referring directly to gynae. I've seen some stuff in the chat about 2-week wait immediately. Have I missed anything? I'm trying to breathe through, so I'm sorry if I've missed anything. Isn't over 60 plus change in bowel habit a 2-week wait? Yeah, I guess so for what do you call it? Colorectal cancer, but that wasn't an answer there, I'm afraid. So potentially that's why. But yeah, you're right. If I've made a mistake, please let me know. This is just like one of these stupid UCL niche things. Don't deep this at all. Yeah, okay. So I see why you've all gone for A. So this is the most common type of ovarian cancer. This question, I appreciate it might not be the best written, but I'm just sort of trying to highlight, like what UCL are like, and they'll throw in some dumb histology and these niche words. But yeah, serous cystic adenocarcinoma is the most common. But the reason why I thought this was a Krunkenberg tumor was due to the fact that she's got a previous history of gastric cancer as well. So this is just basically some niche tumor where it's an ovarian malignancy that's metastasized from a primary site. And you get your signet ring cells. So I've included some of those like keywords. So serous cystic adenoma, Samoma bodies on histology, so they may throw that in. Ovarian, so Krunkenberg tumor, signet ring cells, Brenner tumor, I'd never even heard of before, but apparently coffee bean nuclei, dysgerminoma, most common type of germ cell. These are the ones that present really young, and it's got a fried egg appearance apparently. Yeah, don't deep this question, but now you've seen it, now you've heard of it, you'll never forget it. And then here's some of the histology sides. So I think this first one's meant to be a Samoma body. It's Greek for sand, amos. So it's meant to look like sand, no idea, whatever. I don't know if you can see my slides. So that's the one in top left. And then top right is the coffee bean nuclei. And then bottom left is the bottom right's the fried egg one, and then bottom left is the, what's it called? I don't even remember myself. The coffee, no, which one was that? Ah, sorry. So yeah, bottom left is the fried egg, and then bottom right is the signet ring cells. I wouldn't worry about it too much. You've seen it. Even I couldn't remember what they bloody were. But yeah, just something to be aware of. I think the histology stuff's quite interesting, actually, after I've gone through it a bit more. But anyway, with an eye of faith, you may see some of those things, as what's his name used to say, Greg Campbell. Anyway, someone can use it themselves again. Top left is the Samoma body, meant to look like sand, whatever. Or it's Greek for sand anyway. I don't know what it's meant to look like on histology, but there you go. I should have labeled them. I'll re-upload these and label them. Sorry, that's my bad. Anyway, contraception. So basically, I'm going to do this as a OSCE. I'd encourage you to sort of go through the contraceptions in your own time, and their risks and what do you call it, how they work and whatever. Just briefly. You don't need to sort of know the ins and outs of it. I never learned the ins and outs of how they all worked, but just be aware of the different types and what they're used for and how patients might prefer them and stuff. But this is just basically an OSCE structure. If someone came asking for oral contraception or emergency contraception. So what's contraception? Abstinence. Anyway, we'll crack on. So Sally is 23 years old and is inquiring about starting the combined oral contraceptive pill. So open questions to start. I understand that you'd like to start the pill. Could you please explain a little bit more about why? Like why do you want to start it? Remind patient that everything is confidential, but tell them if they, so this might not come up as much because it's in peds, like underage children and Gillick competence and all that sort of stuff. But it's a reminder to tell them that everything's confidential. But as I mentioned before, if in the history they mention anywhere that they're in danger or there's something not quite right going off, you may need to inform your seniors or even the correct authorities. So it's just something to be aware of. We'll rattle through this because you guys want to break before you have your next lecture. So explore other contraception choices. So she's come in saying she wants the combined. Just explain why. Why this one? Do you know of any other types? Are you interested? Would you like me to explain more about them? So it's better to do this than go off on some tangent and delve into all the knowledge you know about the IUD and IUS and progesterone only pill, and you've just wasted 3 minutes of the station when they didn't even want to know about it. So it's just always important to basically take a step back and ask them what they want to know. As I've sort of mentioned there, they hopefully won't draw you down a route where you've got to explain everything, because they'll just say, I really want X, for example. Cool. So key things basically you need to ask about before starting someone on contraception. The sexual history. So are you sexually active? Regular partner. Do you feel safe with your partner? STI screen. It's kind of similar to what we've spoken about before. So you want to do a good thorough sexual history, menstrual history. So last menstrual period, cycle length, any problems with your menstrual cycle. So, do they have painful periods or heavy periods? Go through their contraceptive history. Have they ever used any before? Are they currently using any? Have they ever had any bad reactions before? If so, why do you want to change? Any chance that they could be pregnant, because sometimes you can't be starting it if they're pregnant. So important things to sort of go through. So past medical history and family history is where it sort of gets a bit important, and the specific things you need to ask about. Go on, and then what sort of things would you want to be asking about in this, basically? Yeah. Do you have a pregnancy test before you start contraception, GP? Yeah, I imagine probably you might have to do. I actually don't know. But yeah, VTE, cancer, breast cancer, migraine with aura, nice. Smoker, BMI, yeah, good. If they want IUD/IUS, would you have to do STI screening before? Potentially. I actually I actually don't know how it works in GP. They're good questions. I can look that up for you. But I imagine yes. Yeah, drug history, we were going to get into that. So anti-epileptics, family plans. Yeah, you guys have smashed it. So migraine with aura, breast cancer, breastfeeding, high BMI, any clots, stroke, heart disease, diabetes, blood pressure, any liver problems, any active cancer. So social history, you guys have answered it anyway, but like smoking can be an absolute contraindication. BMI as well. And once again, you could fit in asking about home life here and social side of it. Drug history, so we've spoken about already. Perfect. Cool. So, and then maybe you might need to explain how they take it. So 21 pills taken at the same time every day, 1 week off, withdrawal bleed in the 4th week, where you take no pills, new packet after 7-day interval. Can do back to back. So you can do 3 months of pill taking and then take a break if you wish. And then, can I start it today? So ideally you start it on the 1st day of the bleed. Otherwise you have to wait 7 days before it becomes effective. I think progesterone, it's only 2 days. Side effects. So side effects as long as your arm. I'm sure you all know them, but common ones to sort of mention. So, you might get headaches, you might feel a bit sick, mood changes, breast tenderness, increased weight. They don't protect from STIs, breast cancer, stroke, MI, etc., etc. So important things to mention as well. Missed pills as well, quite important. So if patients miss a pill, if they miss one, just take it as soon as you remember. It may mean you have to take 2 on the same day. If you've missed 2 or more, it depends on when in your cycle. So basically, I think if you've had 7 days worth, it sort of gives you good enough protection. But basically, in week 1, you consider giving emergency contraception. Week 2, nothing, as long as there's been at least 7 days of pill taking. And then week 3, you sort of don't do anything, but you just omit the pill-free interval, so you carry on taking, basically. That's very basic. And then just to finish off, we'll go through emergency contraception station. So again, I'm just going to ask about like the key things. I'm not going to go into too much detail. So basically, what happened? You got to talk about unprotected sexual intercourse. So when, what, previous emergency contraception in the cycle, any chance you could already be pregnant. Obviously, you're going to do this in a sort of, empathetic manner. I'm just saying it here for sort of just to let you know what you need to say, but obviously you wouldn't just come out with what, when, why. I'm sure you guys know how to phrase these sort of things. But these are the sort of things that you want to be asking. Basically, you need to ascertain whether or not they need it as well. Sometimes they may not necessarily need it. Are you on any current contraception? If so, why did that fail as well? You can ask about that. You need to ask about the menstrual period again. So basically, you've got to sort of do this working out. I think Jane Kavanagh has the ultimate sort of slides and lecture for this. I wouldn't be able to do this topic justice. She's the one you need to sort of go to and have a look at. But basically, sort of length of cycle, how regular, when was the first day of cycle. So you just need to work out the ovulation date. So in a 28-day cycle, this is roughly at day 14, and the most fertile days are day 12, 13, and 14. So past medical problems as well is quite pertinent. So any gynae problems, do they have like any abnormalities that may make fitting an IUD quite difficult? Are you breastfeeding? Are you up to date with your STIs? Smears up to date. Asthma as well. So if you've got severe asthma to the point where you're taking steroids, it's a contraindication to LO1. Wilson's disease as well, interestingly. Well, you can't give the copper coil if they've got Wilson's. Drug history, so once again, ask about anything that may affect the enzymes, your enzyme inducers. So you've got 3 options, basically. 3 options, so 11L. So you take this within 22 hours, single dose, but double up if the patient's got a high BMI or they're just have a weight over 70 kilograms. This doesn't disturb the menstrual cycle, but if they vomit, they need to come back and the dose should be repeated. And this one can be used more than once in the same menstrual cycle. LO1 is the one that you can take within 5 days, but it can affect hormonal contraception that you're already taking. So just something to be aware of, 5 days of barrier methods. And as I've mentioned, don't use in patients with severe asthma. And it now can be used more than once in the same cycle. I believe it wasn't the case before. And then obviously the IUD is your last one. This is the most effective and it provides long-term contraception. So this is something that you may want to counsel patients on. Yes. And also importantly, so it can be fitted up to 5 days after the likely ovulation date as well, as opposed to just 5 days after. So you can get side effects from it, and you may want to do an STI screen, speak about further contraception and pregnancy test in 3 weeks. Brilliant. So that was a quick whistle-stop tour of what I think is the most important things in gynae. With regards to the emergency contraception one, they may give you a patient who's like, I want the pill, and they're very adamant on that. And then you may explore and find that they actually can't have it. So just something to keep in mind. Also, don't forget about the history of asthma and stuff. But that completes the presentation. Does anyone have, Ed, did you have a feedback form as well? That'd be great. And if there's any questions you guys have, feel free to just shoot me a message, because I appreciate you've got another lecture and you might want to chill for a bit. Right. Okay. So it comes up every year. I'm pretty certain it came up. Is that what someone else has just said? Feedback form, cool. So basically, the FGM question, the answer to it is they give you the option of call 111 or call 999, and basically don't. And you might know this already, but the answer is call 111, not 999. Basically, even though it is like illegal, and obviously that it shouldn't happen anywhere, basically. But in the UK, it is illegal. Just sort of be aware that the answer with call 111 is the correct one, not 999. Oh, 111 or 101. It's 111, I think. I should have double checked it. Sorry. Call 101. Whatever Jane says, yeah, bang on 101. And this will be an SBA potentially, more than likely. But just don't call 999 if that's the correct answer. But that's what I was going to include as the final SBA, and I realised I've forgotten, so apologies for that. Would you say that, right, so anything else? 111 non-urgent police. I actually can't remember what the number is for, but that is just one. 101 is the police, yeah. That's what you're calling. But just basically don't call 999. I should have double checked it, sorry. What about if she's over 18? It's still illegal, so you still have to do it. Also, Mr. Non-clinical question type things at the start. Could you please quickly recap? No, the non-clinical things. Yeah, so like ORS, abortion. They asked us a question, I think, about abortion, and it was like, how long after the abortion is the patient likely to experience like PV bleeding? And I remember it, but I had no idea. So, yeah, double check that. Even if over 18, you still call 101. Pretty certain, because it's illegal. It's a criminal offence, basically, for it to happen. Yeah, but need patient consent. Either way, that's the correct thing. Yeah, so I've just mentioned the non-clean stuff. So learn about the ORS. If you scroll back in the chat, they sort of mention it as well. What else did we mention? Bloody hell. Oh, patient motivation. Yeah, I'll sort the notes out as well. Has the lecture ended, Sean? Yes, mate, we've just finished. Yeah, I'll sort the notes out. I'll also, this is my last lecture actually, so I'll sort out some potential OSCE stuff. So I might like a Google form and get you guys to sign up when I've had a look. Anything else that you want to ask in general? Not just about gynae. FGM quick points. Illegal, call 101. It's a good one, Sean. I definitely recommend. No, you don't need to know the different types of FGM. I didn't know anyway. It's all illegal. So no matter what, you're still going to, report it to the police. Call 101. Is OSCE difficult? Like I said, we didn't do one. But generally, if it sounds dumb, but the more you prepare, the easier it is. I must admit, I didn't prepare very well for finals, and I found it quite tough. In fourth year, I prepared a lot better, and I thought it was a breeze. It's almost quite fun. Like it's just different. It's a bit better than SBA. You get into the swing of things. Can you show us your hair? I also saw some crap about my eyebrows earlier on as well. That wasn't funny. That was definitely Adam.